Okay, thank you. Thank you very much for the opportunity to come present. I've been looking forward to this since last year when this all began, putting this conference together. So yes, I am formally trained as a heart failure cardiologist. I have to say I spend probably three-fourths of my time on sports cardiology, which really is a passion. And I'll make the argument today that this is something that everyone in the room, if you are at all even tangentially related to cardiology, this is something that you should be thinking about because it manifests in many ways, shape, and form. And I've just listening to the presentations this morning, it already has come up a couple times. These are my disclosures for the talk this afternoon. So what do we do in sports cardiology? I cannot in 20 minutes go over everything that a sports cardiologist does, but there are a few essential aspects of what we do. Number one, preseason assessments. This in and of itself is a very controversial area. We ultimately are trying to reduce the risk of sudden cardiac death in athletes, but the question is, what's the best way to do that? I cannot go over all those data. That would take hours to do, but that is an essential aspect of what we do. Number two. Thank you. Number two, trying to determine whether or not the heart of an athlete, the changes that we see, the structural and functional changes are the result of structural remodeling as a result of a lifetime commitment to athleticism or the development of pathology, trying to distinguish, for example, hypertrophic cardiomyopathy or a dilated cardiomyopathy from the structural changes that we would anticipate from a lifetime commitment to athleticism. Number three, establishing training zones for individuals trying to improve their athletic performance. Number four, trying to determine whether or not an athlete is eligible or not to participate in their sport. Environmental medicine is a very exciting area when we start to think about our athletes engaging in their sport, when the temperature is changing, when the level of hydration is changing, when there's less oxygen available if you're exercising in the mountains. Tactical athletes, those are defined as individuals who use their sport and fitness as a service to the community. Military, SWAT, firefighters, those types of things. We're not using our sport for performance or competition, but rather to serve the community. Some very unique aspects of medicine as it pertains to management of the hearts of a tactical athlete. And then things that are very relevant to all of us. I think I heard Dr. Mazur talking about AFib in athletes earlier today. What I'm going to focus on in the short period of time that we have is coronary artery calcium in athletes. I will say that it's not all work. Some of it is fun. I have the pleasure of being the sports doc for some of the professional teams in Denver. And when the Nuggets won the championship last year, we were awarded with rings, which is a small perk to the job. Unless you guys know something I don't about the Broncos, I'm not getting a ring from those guys. So I'm just going to enjoy this little one I have here for time to come. So as we start to think about CAC in athletes, just as a reminder to set the stage for where this is going, if you look at the 2018 guidelines on management of blood cholesterol for individuals who are at an intermediate level of heart disease, coronary artery calcium scoring is recommended to help redefine their risk and decide how you're going to treat these individuals. CAC is 0, no statin. If CAC is 1 to 99, favors a statin. If CAC is over 100, then we would treat with a statin. So here's a case of a athlete that I saw not too long ago, 53-year-old man, no past medical history, not taking any medications, exercises routinely 8 to 12 hours per week, runs at least 8 miles per day. Current running pace is about 8:30-minute miles. He also includes cycling in his regimen, and he's maintained this level of exercise intensity since high school. He's completed over 25 marathons, and his PR is 3:05, so pretty good athlete. Recently obtained a CAC score and came to me to see what we should do about this, 680, and then here is his 10-year risk, 7.6% based on his demographics and risk factors. And then he comes with a lot of questions. Is it safe to keep exercising? Do I need a stent? Should I start taking any medications? Well, I'll make the argument here that CAC, abnormal levels of CAC are actually pretty common in people who have a lifetime commitment to exercise. We're probably all familiar with statistics like these. We're looking at the risk of MI stratified according to the frequency of exercise. And what you can see here is that it doesn't take a lot of exercise to dramatically reduce the risk of myocardial infarctions in the general populations. Nevertheless, if you look on an epidemiologic level, the risk of sudden cardiac death on a population level is actually highest in individuals the older they are. SCD is much less frequent in younger populations, much more common in older populations. Nice studies that have come out of France, if you look on a societal level, just some statistics that you might want to keep in your back pocket. On average, about 4.6 events per 1 million residents of sudden cardiac death. The majority are men. 90% are men, and the average age of sudden cardiac death during athletics is about 48 years, so not young, middle-aged. And the majority of these events occur during recreational activities. And I underscore recreational because I don't want you to leave with this assumption that these things only happen during professional events. We turn on ESPN, we see bad things happening, but you should be aware that the majority of sudden cardiac death events are actually occurring in recreational athletes undergoing recreational activities, not professional athletes on the rink or on the football field, though that does gain a lot of media attention. Like I said, CAC is common. For the most part, its prevalence is similar between athletes and sedentary controls. This is a study comparing athletes versus sedentary controls. And these athletes were pretty well trained. On average, were exercising for 31 years and had completed 13 marathons. And if we look first just at their CAC scores, for the most part, CAC scores are similar between athletes and controls. But there's something about the male athlete, and I want you to hold on to this because this is going to come back in a few minutes. Male athletes have a higher percentage of coronary plaques than sedentary males, 44% versus 22%. The only participants with a CAC over 300 were male athletes in this study. Interestingly, the number of years of training was the only variable that was associated with the risk of CAC over the 70th percentile for age or a luminal stenosis over 50%. Now, this is where things get a little more interesting. When we look at the morphology and the distribution of CAC in athletes versus controls, for the most part, athletes have calcified plaque, whereas non-athletic controls have mixed or non-calcified plaque. And if we look at the distribution of plaque, the majority in the study were in the LAD. And if we look at the athletes themselves, we can see perhaps a broader distribution. And if you look at the bottom graph, this is showing you the distribution of, frequency of stenoses and the severity of it as well. And it's really only the athletes that have significant levels of stenosis. You don't see that in the control population. So underscoring this point, that CAC is common in athletes, and it may not be trivial. But the stable nature of the plaque, and I use the word stable because the majority of plaque in athletes is calcified, we could question whether or not that mitigates the risk of plaque rupture in acute MI in these patients. Going back to my case, the patient comes in with a CAC score over 600 and wants to know if he's at risk of having a heart attack and should he stop exercising. So what do we do with that? In addition, there are data to demonstrate that the heart of an athlete may have evidence of scarring or delayed gadolinium enhancement. This is a fun case that I like to show. This is a 46-year-old ultra-endurance athlete whose plan was to run across the country or cycle across the country. He made it 17 days, then had to stop due to a musculoskeletal injury. But if you look at his baseline MRI and his follow-up MRI, you can see that there's an increase in LGE, primarily in the septum and also in the hinge points as well, suggesting that there's something going on with engaging in endurance exercise that increases the inflammatory response and contributes to the development of scar formation in the athletic heart. This actually is common among athletes. Here's an MRI study on almost 100 endurance athletes and 72 age-matched controls. The major findings of this study, just looking at MRI of the heart, focal enhancement is more prevalent in endurance athletes versus controls, 38 versus 3%. And then enhancement was always, when it occurred in athletes, it was always located at the inferior RV insertion sites or the hinge points of the heart. Delayed enhancement in this study did not interfere in any way with ventricular function and also did not contribute to arrhythmias or anything like that. So when you see delayed enhancement in the athletic heart, it is thought for the most part to be a benign phenomenon. But nevertheless, it is common, is something we need to be aware of. But back to our case. There's uncertainty here regarding what to do with athletes who come in with high levels of CAC. Are they at an increased risk of adverse events Do they need to stop exercising? And is there an indication for statins, aspirin, stents? What do you do with these individuals? Well, this was a very nice study that came out about 5 years ago now from my mentor back in UT Southwestern, Dallas, Texas, where they tried to ask these questions or answer these questions. Their primary objectives here were to determine the association between CAC with varying levels of physical activity in a very large cohort, 22,000 individuals followed for over a decade. And then number two, determine whether or not physical activity increases mortality among these athletes. Like I said, 22,000 individuals on average, 52 years old, predominantly male. So these are not young competitive athletes. These are master's level athletes who were followed for over a decade, like I said. They stratified these individuals into three groups according to the level of exercise that they participate in. So over 3,000 MET minutes per week, 1,500 to 2,999, or less than 1,500 MET minutes per week. Well, what does that mean? Well, as a reminder of what a MET minute is here, if you're exercising over 3,000 MET minutes per week, that equates to about running 6 miles per day at a pace of 10 minutes per mile. What do the AHA guidelines recommend? They recommend 150 minutes a week of mild to moderate exercise, which would get you about 500 MET minutes per week. So just to give you some context here, when we talk about a 4,000 MET minute per week level of exercise, that's a lot of exercise. This just breaks it down a little bit more to give you a flavor for the degree of physical activity. Here on the y-axis, we're looking at the level of the number, and then on the x-axis we're looking at physical activity in MET minutes per week, and then the inset there is just showing you that this goes out to about 10,000 MET minutes per week. So these are heavily dedicated individuals to their exercise. And then when we look at the risk of CAC, having a CAC score over 100, the risk increases in proportion to the level of physical activity that you engage in. When we actually look, we break this down a little bit more at the CAC scores and the outcomes here. Again, they've stratified the data according to the degree of exercise that you engage in. So we can see the average CAC scores. These are not trivial. These are high. We're looking at CAC scores in the 600 to 800 range, sometimes pushing 900 to 1,000. Number of calcified lesions. And then we look at all-cause mortality and CVD mortality. This is where things get interesting. When you look across from left to right, you can see that as your physical activity level increases and your CAC score increases, the hazard ratio rather, of all-cause mortality and CVD mortality actually declines. If you look at athletes with any level of CAC, so just having a score over 1, we see a similar trend that compared to the reference group who does the least amount of exercise, the risk of all-cause mortality actually declines among individuals who exercise at the highest levels and have higher levels of CAC. So the conclusion from this study is that exercise does not appear to increase the risk for individuals with high CAC. It may actually be protective for individuals who exercise for any level of CAC that they do have. Why is this happening? It's not entirely clear. A lot of things have been proposed or hypothesized. As you can imagine, this would be a hard patient population to study, but a lot of things have been thrown out here. Endothelial damage, exercise-associated hypertension, mechanical bending of the coronary arteries for prolonged periods of time, particularly in the right coronary artery, oxidative free radicals that are generated during excessive exercise, exercise-induced vasospasm, inflammatory responses that occur with systemic exercise. But one of the interesting things to remember here is that there may be a protective benefit for females. In all of the data that I've shown you, we don't really see high levels of CAC in the female endurance athlete. This appears to be a predominantly male phenomenon, and there is some evidence to suggest that females may be protected from that. Now, as I said, when we think about sports cardiology, it's not just taking care of the professional athletes. A lot of it are recreational individuals and people who get into trouble engaging in endurance events of all sorts of shapes and sizes. And one of those are these ultra endurance events. Marathons, for a lot of people, are just the beginning. A lot of people are doing 24 to 48 hours, sometimes even longer endurance events. And when you do that, weird things can happen to your heart. This is a picture of an athlete completing an invasive CPET, the cycling portion of an ultra marathon. So this is 120 kilometers racing in our lab with a catheter coming out of his heart to try and better understand what's happening to his heart during exercise. And one of the things that you see, and we should all be aware of, is that during a marathon, or during an endurance event, you actually can develop right ventricular failure. And we see that if you remember anything from pressure volume loops, we're not going to break these down, but go back to first year med school and you remember that the wider a pressure volume loop, the greater the stroke volume, and then it narrows again. And we see that after about 3 or 4 hours that the RV is starting to struggle and cardiac output is going down and declining, and the body is doing some interesting things to try to compensate when that starts to happen. Why is that relevant? Well, if you have somebody who has a high level of CAC and is at an increased risk of having a coronary event, you probably want to keep that in mind when they see you and ask about whether or not it's safe for them to compete in a marathon. And these are some interesting data to demonstrate that the RV struggles kind of in a dose-dependent fashion. When we think about the duration of an event, whether it's a short marathon or whether it's an ultra level event lasting for longer periods of time. And then when we need to also remember, we're here in New Mexico, we're at altitude. People come from low level altitudes and they go straight to the mountains without any time to acclimatize. We've spent a lot of time trying to better understand what happens to the heart when that happens. Well, a couple things that you should keep in mind. This is just looking at the heart of healthy individuals that we should be thinking about how to apply these data to individuals with heart disease, hypertension, and heart failure or uncontrolled arrhythmias. But when you exercise at altitude, heart rate is higher for any given level of work compared to normoxic levels. Blood pressure is lower during the acute phase. And I want to point your attention to this bottom left graph. Look how low these oxygen levels go when individuals are exercising. This is around the equivalent of Summit County in Colorado, so somewhere on the order of 12 to 14,000 feet. But it's important to consider because it's a popular tourist destination. How low these oxygen levels are getting. Some individuals are down into the 55 to 65% range. And then also there's a significant reduction in the ability to exercise. The VO2, which is the gold standard metric of functional capacity, is dramatically lower when you exercise in the mountains. So when we apply these types of data to our patients with cardiovascular disease, we need to be ensuring that we're optimizing medical therapy and controlling CVD risk factors prior to exercise in these remote and austere environments. We did put together an AHA position paper a couple years ago, trying to call attention to this because this is a very common phenomenon in Colorado where individuals come from low altitudes to vacation and unfortunately suffer from acute cardiovascular events. And we need to be doing a better job of risk stratifying our patients, optimizing medical care before they go into these austere and remote environments and putting themselves at risk. This is just an illustrative figure in closing here to demonstrate the degree to which functional capacity declines when you go to altitude and you try to exercise. So you can see Summit County there kind of in the middle. That's in Colorado, anywhere from around 10 to 12,000 feet, a little bit higher maybe. There's about a 10% reduction in your ability to exercise. Well, healthy people may not think anything about that. But if you're at a low altitude environment and you have mild heart failure with a VO2 of around 18, that can be a significant reduction in your ability to exercise and may make it difficult to even walk around. So that's something that we need to be thinking about when we're seeing our patients before they are beginning either an exercise program or they're planning to vacation in the mountains. So in summary and closing, athletes with higher activity levels generally have higher levels of CAC. At any level of CAC, their higher activity levels are associated with a safety and a reduced risk of mortality. I would argue, though, that it's still helpful to know the CAC score for high volume exercisers, since high CAC scores are associated with higher risk at any level of physical activity. We should be mindful of the physiologic demand that's associated with the event an athlete is planning. Consider the impact of external and environmental factors, temperature, hydration, hypoxia on cardiovascular performance, especially in individuals with CVD or CVD risk factors. And then I would argue that decisions on treatment really should be personalized and the result of the shared decision making to balance benefits and risks of treatment, especially when we think about aspirin or blood thinners or statins. Those can be risky when you have an athlete in a remote environment when they're at risk of bleeding from an injury or if they're dehydrated and running a risk of developing rhabdomyolysis. These are not always straightforward questions to answer. With that, I'll stop and thank you very much again for the opportunity to share.
Do people have some questions?
A lot of the athletes that I work with, both in the office and outside the office, are concerned about the effect of statins on training. There's some evidence that the statin mitigates the training response in the muscle. And so I wonder what advice you give your endurance athletes who are in that higher risk category.
Thank you. Yeah, so the question was, athletes have a lot of reservations about statins due to the concern that it might mitigate or reduce the training effect. And I would agree with you. That is one of the biggest concerns that athletes have. They're, on the one hand, they're very concerned with their abnormal CAC. On the other hand, they don't want anything to interfere with their training. And sometimes you need to have an honest conversation with them. That's the best advice that I have. And we have long conversations about that.
I mean, is there a study that suggests that statins interfere with?
The question is that true or not? Real or perceived? The problem is that athletes believe that is true. Athletes believe that is true. And they want you to find any way that you can to reduce their risk without impairing their ability to perform and also putting them at risk. And that's where I've just mentioned the issue with rhabdomyolysis. That's another one of their major concerns about beginning a statin. And to answer your question, all I do is I try to have a very honest conversation with them as best I can tell. This is your risk based on what I know. These are the benefits of taking a treatment, and these are the risks of not taking it. And it's also, I would not minimize the importance of doing that, because we do have a lot of individuals who, after having that conversation, will turn down statins, and then something will go wrong. So the best we can do is arrive at a shared decision-making process after a very informative discussion.
So a lot of these people are seeing people who are not super athletes.
Mhm.
The question is, the patient comes through, they've been exercising. Is there really any value in doing stress testing or other evaluation? And someone says, I already exercise. My wife is worried that I'm going to drop dead while I'm exercising. That's always a problem. And so the question is, what is your feeling about working up people who have that?
So the question is not the elite athletes, but the normal individuals, whether or not we should do stress testing to try to risk stratify. If patients are coming to me with a concern, I generally will not do stress tests on asymptomatic individuals. But if individuals are coming with a concern about their risk, then I generally have a lower threshold to do one. Sometimes I'm not just looking at whether or not they develop ischemia during exercise, but I also really want to know what the heart rate and blood pressure response are. And then I also have a low threshold for ordering CPET testing, because that is much more informative when we're trying to understand and characterize the individual's ability to exercise and what factors we need to be thinking about or addressing that they may not have thought of. So
would concern you when they see someone, they do a stress test. What are the signals that make you worry that, gee, maybe you should not exercise?
the question was, what signals of harm would I see that would tell me that they should not exercise, or they should at least exercise, I would say, smartly. I would argue that very few people should not be exercising. That the argument we're trying to have for the most part is getting people to get up and walk. And we really should remember when we're counseling our patients about exercise, you don't need to go to a gym and get a membership and get sweaty and hot. You know, if you just follow the guidelines, really what we're talking about is 30 minutes a day, 5 times a week. And that's really the level of conversation that we're trying to have. But as far as the question here, the biggest concern, quite honestly, is when I see uncontrolled hypertension. That seems to be the biggest, most common thing that I see on stress testing is people come in with normal levels of blood pressure, and then at submaximal levels of exercise, their blood pressure skyrocket, which tells me we need to be doing a better job of treating blood pressure, which, as we all know, is one of the major risk factors for cardiovascular disease and heart failure. And then the last thing that I would say about that is when we do stress testing, we have a tendency to just flip towards the maximal peak level of exercise. And when you do that, you really miss out on the good data. Our patients are not exercising at their peak effort. They're exercising at submaximal levels of exercise. So if you're doing a Bruce protocol, that's 2, 3, 4 minutes into a Bruce protocol. That's where your eyes need to go to see what's happening to the heart rate, blood pressure, and the EKG. You don't just flip to the peak stress portion of the test. We need to be looking at the submaximal level of effort, which is where patients tend to live. And that's where you really find a lot of the good stuff and the signals of harm that we need to be treating.
Well, thank you very much.
Yeah, thank you.
That was great.
Thank you.